either in the form of tense nailling or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is that tense nailing, unlike conservative management, it provides stable fixation and early mobilization and reduce the risk of non-union and malunion. Tense is less invasive, resulting in smaller incision, reduced soft tissue damage, and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on how the state head was the other mode of the trauma. So these are the typical mode of injury, the fall of the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and screw. So these are the already explained. The simple fracture we have taken into consideration. Displaced simple fractures, either spiral or oblique or transverse or short of 15D1 and D2. The patient tries to find if you are affected, lip elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed midge. The incision is small incision, either transverse or longitudinal incision, about 1 to 1.5 centimeters, just lightened to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take its own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate course of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result is 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bypass, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15D1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15D1 fracture treated by titanium elastic nailing. Yet another case of 15D1 fracture treated by titanium elastic nailing. These are the 15D2 fracture. This is 15D3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see that 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see. So the time is less. So the limitation of this surgery is a small number of cases included in this case. in this study, so the short follow-up period and retrospective design, so a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further studies are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. 17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a Gallagher fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we called the Gallagher fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing. And ideal treatment for this Gallagher fracture is the plating, but I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Gallagher fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Gallagher fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this radius, the Gallagher fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. But I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And The tense swelling provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained and DRUJ should be reduced properly. We followed the throughout 11 months for this maintenance of the length and DRU maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And with the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences. Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. TENS is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years and no comorbidity was found in our study group. All patients treated with titanium elastic nailing. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is a floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture, only the thumb and index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. Mini open reduction of the fracture. So this is another case we did, the 15B1 fracture again treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the entry site you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and the prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटनल नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सी आर्म के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिटर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल, और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टीरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर्म को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टीरियर स्क्रू को डाल दिया गया है जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर्म को एडजस्ट किया गया है, और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था ये। हुआ था। ये लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला। Hello friends, today I am going to give a demo of interlocking nailing in. ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि आप देख सकते हैं काफ़ी डिफॉर्म्ड हो गया है और एक दूसरे में चिपक गया है। कूल्हे का हड्डी कूल्हे का गोला कप में चिपक गया है और काफ़ी हड्डी बन गया है उनके। इसके कारण काफ़ी रेस्ट्रिक्शन मूवमेंट में उनको हो रहा था। वे ठीक से बैठ भी नहीं पाते थे कुर्सी पर। ये है एक्सरे पिक्चर, जिन्हें टोटल कूल्हा उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में। और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर कूल्हा को बदला गया है, उनको पैर रखना, उस पैर को रखना है, उसके बाद अच्छे पैर को रखना है। और चढ़ते समय पहले अच्छे पैर को ऊपर रखना है, उसके बाद जिसमें कूल्हा को बदला गया है उसको रखना है। ये अब ऑपरेशन के बाद ये कुर्सी पर बैठ सकते हैं, इवन लो चेयर्स पे भी बैठ सकते हैं और काफ़ी कंफर्टेबल और पेनलेस मूवमेंट ऑफ नी जॉइंट। बिना सहारा के 10वें दिन बिना दर्द के चल पा रहे हैं।
छपरा के डॉक्टर RC ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOA 25 में दिया गया है। और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है जिसमें मेरा नाम आया है। The supine position of the patient with a bump in the interscapular space, in which position I do interlocking nailing of humerus. With the traction only, with the assistant, both sides, the traction is given, and external rotation of the proximal fragment is done with the hand only. As you can see in this picture, evident in the fluoroscopy picture, you can see, and I am externally rotating the proximal fragment to see the lateral view of the fracture. So after reduction of the fracture in both AP and lateral view and confirmed on the fluoroscopy picture, we make we introduce a 2.5 millimeter or 3 millimeter KY or steamer pin percutaneously at the selected entry point, both in AP and lateral view. The entry point is usually in AP view, it is at the point at the junction of the articular and non-articular fracture. And lateral view, it is in the line with the intramedullary canal. So, if the fracture is in the upper part, upper fourth of the humerus, the entry point is in a AP view, it is in intra-articular surface of the humeral head, because it should be central in both AP and lateral view. So I am introducing 2.5 millimeter steamer pin percutaneously at the selected entry point. You can see this is the AP view. I am selecting the entry point. It is intra-articular portion of the, you can see in this picture, because the fracture is the upper fourth of the humeral shaft, and this is the lateral view. I am seeing it in the lateral view. It is inside in the line of the intramedullary canal, and it is inside the intramedullary canal in both an AP and lateral view, confirmed in the fluoroscopy picture. I am exchanging this statement pin with a kind wire. A 2 millimeter kind wire is exchanged for this statement pin, 2.5 millimeter statement pin, and after making a stand hole, after making a small ring in the rotator cuff, and this is my guide wire. Guide wire is inside the proximal fragment in the proper position, and it is inside the distal fragment. As you can see in this picture, the 8 millimeter remark is inside the distal fragment is introduced. So after removing, we introduce a 7 millimeter nail of KY cross each other. The bisecting point in the middle of the proximal hole, dynamic hole, will be my point of incision in the skin. So after putting about 1 to 1.5 centimeter length skin incision, we do dissection, soft tissue dissection with the fingers or the artificers, and then 1.5 millimeter. After drilling, we have put both the screws. You can see in AP and lateral view, well-sized screw and well-placed screw inside the hole in both AP and lateral view. So I am putting the proximal screw down. You can see that the nail has been buried about 5 millimeter from the articular surface inside the intramedullary canal. The first screw has been put with the help of a jig and drill sleeve and the sleeve. Both the screws have been put. The well sized screw you can see, and I am confirming it in oblique view as a lateral view, even along with the jig. You can see that the jig is in place, and still I am confirming it whether it has gone inside the hole properly or not, and well placed to both the screw inside the both hole, well sided screw in AP view, and well placed screw in the lateral view also. So this is the last step, and lateral view and native view of fluoroscopy picture. You can see this is the lateral view, well placed distal screw, well placed distal screw, and this is the native view, and you can see the final position. There are two skin incisions, one for the entry of the nail and other for the proximal to the screws. So these are the last confirming fluoroscopy picture. You can see the well placed both screw and well buried nail about 5 millimeter from the articular surface. This is the fracture. You can see there is a communicated fracture. There is no distraction. Okay, thank you. आज मैं आपको